The journey to parenthood is often envisioned as this clear, natural path. We're told certain things, we expect certain timelines. But for countless individuals and couples, that path can be filled with twists, turns, and unexpected challenges that are rarely talked about. It's a deeply personal experience and often a really difficult one. Today, we're taking a deep dive into fertility. We'll be unraveling what infertility really means, its many surprising causes, the cutting edge ways doctors are diagnosing and treating it, and importantly, tackling some common misconceptions that can add to the stress of an already challenging time. Our mission is to cut through the noise, give you the solid, evidence backed facts, and help you feel truly informed and perhaps, a little less alone if this topic resonates with you.
And we've gathered a truly robust collection of sources for this deep dive, pulling insights from the latest medical reviews and compelling personal accounts. What's compelling here is how these different perspectives converge to illuminate a landscape that's both clinically complex and profoundly human. We'll be exploring the science, the options, and the emotional realities, all grounded in evidence to give you a comprehensive understanding.
Okay, let's start by demystifying the term infertility. When we talk about it, it's not just a casual term like it's taking a while to get pregnant. It has very specific medical criteria, right? And understanding that can be the critical first step for many people who are quietly struggling. Medically, infertility is defined as the inability to get pregnant after 1 year or longer of having regular, unprotected intercourse.
Precisely. And that definition provides a crucial benchmark for when medical intervention might be beneficial. It's not meant as a judgment, but as a clinical starting point. And here's where age becomes a critical factor. For women age 35 or older, that time frame for seeking medical help is actually shortened to 6 months.
6 months, okay.
Yes. This adjustment reflects the natural decline in female fertility that, well, it accelerates after the mid-30s, making earlier evaluation potentially more effective.
And what's truly eye-opening is just how common this experience is. The Centers for Disease Control and Prevention, the CDC, has some really sobering statistics that often challenge our assumptions about fertility being, a given.
They do. The statistic that often surprises people most is that approximately 1 in 5 women aged 15 to 49 in the United States are unable to get pregnant after trying for 1 year.
1 in 5, wow.
Yeah. And if we broaden that a bit, about 1 in 4 women in that same age group face difficulties either getting pregnant or successfully carrying a pregnancy to term. And it's really important to stress this isn't solely a female issue either.
Right.
For men aged 25 to 49, 12.8% report some type of infertility. So it's a shared challenge impacting many families. This fundamentally shifts the perception that fertility is a straightforward process for everyone.
And the emotional weight of this definition, when you're living it, it must be immense. It's not just a medical term, it's a lived experience. We came across a quote from a BabyCenter community member that really resonated and captures the depth of this journey. Dealing with infertility is a journey and does take time. Our journey lasted 3.5 years before we got our rainbow baby. That really puts the long, often emotionally taxing nature of this process into perspective. 3.5 years. Hashtag 1.2, differentiating primary and secondary infertility. It's fascinating, isn't it? The experience of infertility isn't monolithic. There isn't just a single path. And a key distinction is made between primary and secondary infertility.
That's a vital point. Primary infertility is when individuals or couples have never been able to get pregnant or successfully carry a pregnancy to term. CDC data from 2015 to 2019 shows that 19.4% of married women aged 15 to 49 experience primary infertility.
Nearly 1 in 5 experiencing primary infertility.
Yes, this refers to those for whom the journey to conception has always been a struggle from the outset.
And then there's secondary infertility. As the name suggests, this is the inability to conceive or carry a pregnancy to term after having already had 1 or more children without the aid of fertility treatments. This can be incredibly surprising and, well, heartbreaking for those who've conceived easily before.
Indeed. The same CDC data reveals that from 2015 to 2019, 6% of married women aged 15 to 49 experienced secondary infertility.
Okay, so it's a smaller percentage, but still significant.
Definitely. And this raises an important question. Why might someone experience secondary infertility if they've conceived before? The underlying causes are often similar to primary infertility, but factors like advancing age, changes in overall health, or new lifestyle shifts since the first pregnancy can play a significant role. The emotional challenge for those facing secondary infertility is unique. Many individuals find it perplexing and profoundly disappointing.
I can imagine.
Especially after a seemingly easy first pregnancy. One BabyCenter community mom perfectly captured this sentiment, sharing, I'm at a loss. We got pregnant right away with our prior 2 pregnancies, but nothing seems to be working this time around. I'm truly bummed, and it feels like I should just move on with my life, but I so want another baby.
Oh, that's tough.
It really humanizes the experience and adds an authentic voice to the discussion, reminding us that every journey is personal and previous success doesn't guarantee future ease.
So it's not always just the absence of pregnancy that gives us clues. Our bodies, for both men and women, often send out subtle or sometimes not so subtle signals that something might be off with fertility. The most apparent sign, of course, is simply not achieving pregnancy despite consistent, unprotected intercourse during the fertile window.
That's the primary indicator, certainly, and it helps to put it into context. Typically, about 1 in 4 healthy women in their 20s or 30s will get pregnant in any given menstrual cycle.
Okay, 1 in 4 per cycle.
But for women around age 40, however, this drops significantly to about 1 in 10.
Wow, quite a drop.
Yes. These statistics highlight why recognizing other, less obvious signs and seeking help when needed becomes so important.
And for women, there are often specific signs beyond just not conceiving. Irregular, painful, or absent menstrual periods are really key indicators, aren't they? Because they often suggest issues with consistent ovulation. If your cycles are consistently off, that's a big clue.
Absolutely. And beyond menstrual patterns, hormonal imbalances can manifest in various ways that might not immediately scream fertility issue, but are indeed connected. You might see unexplained weight gain, increased acne, shifts in sex drive, the growth of facial hair where it wasn't before, or even noticeable hair loss.
Things you might dismiss otherwise.
Exactly. These can all be subtle signals that underlying hormonal problems are impacting fertility.
It's the same for men too, right? Their bodies can give clues that it's not just a female issue.
Precisely. For men, signs can include difficulties with erection or ejaculation, which are direct indicators that warrant investigation. There might also be issues with the testicles themselves, such as pain, swelling, or testicles that feel unusually small or firm.
Okay.
Additionally, hormonal shifts in men might be indicated by changes in sexual desire or thinning hair. While these are common signs for both genders, they're also quite general.
Right.
This really underscores the importance of a comprehensive medical evaluation rather than self-diagnosis. These signs raise questions that a specialist can help answer definitively, guiding the next steps. Hashtag 2.2 key causes of infertility in women.
So if those are some of the signs, what are the root causes we see? Infertility in women is primarily linked to issues affecting the ovaries, fallopian tubes, or uterus. All three need to be working optimally for a successful pregnancy, and about 1/3 of infertility cases are attributed to female factors alone.
Yes, and what's truly critical to understand here is how profoundly interconnected these systems are. A problem in one area, say a hormonal imbalance, can have a domino effect on seemingly unrelated aspects. It impacts everything from the egg itself to the uterine environment where it needs to implant.
Right.
Let's start with the ovaries, which are, of course, responsible for producing and releasing healthy eggs.
And one of the most common ovarian issues affecting about 1 in 10 women of reproductive age is polycystic ovarian syndrome, or PCOS.
That's right. With PCOS, it's like your body's hormonal signals get crossed, preventing your eggs from fully maturing and releasing each month. Instead of one dominant egg developing, you get many small follicles that just can't quite get there, like seeds that never fully sprout.
Okay.
This leads to irregular periods and often difficulty ovulating consistently. We heard a powerful story from Kathy Peshek, who shared, "I was told I could never get pregnant on my own with PCOS, but surprise, we did."
Well,
While many women with PCOS do require fertility treatments like IVF, her experience emphasizes that natural conception, though less common, can occasionally occur even with this diagnosis, defying expectations.
so PCOS is a big one. Beyond that, what other ovarian issues contribute to infertility?
Well, there's also diminished ovarian reserve, or DOR. That's where a woman simply has a lower number of viable eggs than expected for her age. Hormonal dysregulation plays a big part too, including conditions like functional hypothalamic amenorrhea, or FHA.
FHA.
Yeah, where periods stop due to problems with the hypothalamus gland in the brain, or primary ovarian insufficiency, POI, which is when ovaries stop releasing mature eggs before age 40.
Before 40, okay.
And autoimmune and certain genetic conditions can also directly impact ovarian function and egg quality.
You also mentioned hyperprolactinemia earlier. Can you elaborate on how that specific hormonal issue affects fertility? It sounds like a bit of a curveball.
It can be. Hyperprolactinemia involves excessively high levels of the hormone prolactin.
Which is mainly for milk production.
Exactly. Think of prolactin as the milk hormone. When it's too high, your body gets confused, almost thinking you're already pregnant or breastfeeding. This confusion directly puts a stop to ovulation, basically telling your ovaries to take a break.
Ah, I see.
This often leads to irregular or even absent menstrual periods and can sometimes cause galactorrhea, that's breast milk production when a woman isn't pregnant or breastfeeding, and contribute to low bone density.
So, what causes these elevated prolactin levels? Is it always a mystery?
Not always. The cause is unknown in up to 40% of cases, which can be frustrating for patients. However, among the known causes, a non-cancerous tumor in the pituitary gland called a prolactinoma accounts for 50 to 60% of cases.
That many. Okay.
Yeah. Other causes include an underactive thyroid, also known as hypothyroidism, certain medications like antipsychotics, antidepressants, and antihypertensives, and even things like chest trauma or severe liver or chronic kidney failure.
That sounds quite complex, but is it treatable? Can women with it still conceive?
Yes, the good news is hyperprolactinemia is highly treatable. Most women who achieve normal prolactin levels through treatment can indeed conceive naturally. The primary treatment involves medications called dopamine agonists, specifically bromocriptine or caprolactone.
Okay.
These effectively reduce prolactin levels and often restore ovulation. Bromocriptine has a long safety track record taken orally or vaginally. Cabergoline is newer, generally preferred due to better tolerance and less frequent dosing, often once or twice weekly. While effective, these medications can have some temporary side effects as your body adjusts, but they're highly effective. For pituitary tumors larger than 10 millimeters, medication is typically used to shrink the tumor before conception. In rare cases where medication isn't enough, surgery might be recommended. So while it can be a significant hurdle, it's one with clear and effective medical solutions.
Okay, so that covers ovarian issues. What about issues with the fallopian tubes? That's the next step in the journey, right?
Exactly. For a successful pregnancy, the fallopian tubes need to be open and healthy. They're the pathway for the egg to travel from the ovary to the uterus and for fertilization to occur. Conditions that can impede this include endometriosis.
We hear a lot about endometriosis.
Yes, it's where tissue similar to the uterine lining grows outside the uterus, potentially causing blockages or distortions in the tubes. Pelvic inflammatory disease, or PID, often resulting from STIs, can also cause significant scarring and damage to the tubes. Previous sterilization procedures, like tubal ligation, obviously block the tubes. And even a ruptured appendix can sometimes cause scar tissue in the pelvic area that may affect the tube's function.
And then, even if the egg gets fertilized and travels down the tube, the uterus itself needs to be ready for implantation. That's another key step.
Absolutely. The uterus must be capable of supporting the implantation and growth of a fertilized egg. Problems here can include structural abnormalities like fibroids or polyps, which are non-cancerous growths, or even congenital structural issues. Endometriosis can also occur within the uterine walls, a condition called adenomyosis.
Okay.
Genetic conditions can affect uterine development, and a history of uterine infection, adhesions, or scarring from previous pregnancies or surgeries, like Kathy Peshek's uterine window after C-sections, can also create issues for implantation and development. Sometimes, even with all these possibilities, the cause remains undiagnosed or unexplained. But that doesn't mean it can't be treated effectively. #TAG 2.3 primary causes of infertility in men.
It's so important to remember that fertility is a partnership. The male factor plays a significant role in about a third of infertility cases, so it's definitely not just about the female body.
That's right. Most often, male infertility is related to issues with sperm cells themselves. This can involve a low sperm count, meaning an insufficient number of sperm, poor motility, where the sperm don't move effectively or quickly enough, or abnormally shaped sperm, which impacts their ability to fertilize an egg. These are the fundamental aspects that need to be in good working order.
What actually contributes to these sperm problems? Are there specific factors?
Several factors can affect sperm production and delivery. Blocked sperm ducts can prevent sperm from being ejaculated. Problems with the testicles themselves, or issues with the ability to ejaculate, are direct causes. Various medical conditions can also impact sperm quality, including things like anemia, diabetes, thyroid disease, Cushing's syndrome, infections, cancer, or even cystic fibrosis. Previous surgeries can also play a role.
And what about physical issues within the male reproductive system itself, not just systemic diseases? things specific to that area.
Yes, absolutely. Structural issues like undescended testicles, where the testicles don't descend into the scrotum during development, or a varicocele.
A varicocele.
Yeah, those are enlarged veins in the scrotum. They can negatively affect sperm production and quality, possibly by raising the testicular temperature slightly. Trauma to the testes or a prior vasectomy are also direct factors. Less commonly, various hormonal or genetic disorders can affect sperm production, making a genetic consultation important if suspected. Even certain chemotherapy, radiation therapy, or medications like anabolic steroids can impair sperm production.
It sounds like there's a lot that can go wrong for male fertility, even if it's not always obvious on the surface.
Precisely. And in some cases, even after thorough testing, a specific cause can't be pinpointed, leading to a diagnosis of unexplained infertility. Experts theorize this might be due to subtle factors, like exposure to environmental toxins, minor variations in sperm function, or maybe a combination of elements that are just at the lower end of the normal range. This highlights the complexity that can be involved and why comprehensive evaluation is key for both partners. Hashtag 2.4, the role of genetics and other risk factors.
This raises an important question about personal agency. While some factors are genetic or beyond our control, understanding the risk factors allows us to make informed lifestyle choices that can positively influence fertility. We often hear about genes influencing our health, but how much do they play a role in fertility?
That's a crucial point. While many genes are involved in fertility, certain conditions that impact it do have a genetic component and tend to run in families. For example, uterine fibroids, endometriosis, and polycystic ovarian syndrome, PCOS, can have a familial link.
So it's not destiny, but it's a possibility.
Exactly. While your sister having a hard time getting pregnant doesn't necessarily mean you will too, family patterns can certainly offer clues and suggest areas for early investigation.
So it's not a definite yes, but it's something to be aware of. What about ovarian reserve and genetics specifically? How connected are they?
The initial number of eggs a woman is born with is almost certainly genetically controlled. Women naturally lose a significant number of eggs throughout their lives, for example, about 130,000 annually before puberty, and around 12,000 annually afterward.
That's a lot.
It is. So if you're genetically predisposed to start with fewer eggs, you might experience an earlier decline. If your mother or sister experienced early menopause, it could indicate an earlier decline in your own ovarian reserve, perhaps running out of viable eggs in your mid to late 30s rather than later in life.
Okay, that makes sense. Beyond genetics, what are some of the general risk factors that can impact fertility for women? Things that aren't necessarily a diagnosis, but increase risk.
For women, age is a significant factor. Fertility starts to decline after age 30 and accelerates noticeably after the mid-30s, becoming naturally unlikely by 45. Extreme body fat, either very high or very low, can disrupt hormonal balance. Chronic diseases like arthritis, diabetes, or thyroidism also play a role. A historical factor includes exposure to diethylstilbestrol, or DES, in utero.
PES.
Yeah, it was a drug prescribed to pregnant women between 1940 and 1971. Having had multiple miscarriages or existing hormonal imbalances are also risk factors.
And what about lifestyle and environmental factors? Are those truly significant? People talk about them a lot.
They absolutely can be. Lifestyle choices like smoking and moderate to heavy alcohol consumption can reduce fertility. Exposure to environmental toxins is also a concern. And a history of sexually transmitted infections that led to pelvic inflammatory disease, fallopian tube disease, endometriosis, or prior abdominal surgery can also increase risk by causing scarring or damage.
What about for men? Are there similar lifestyle and environmental impacts that we should be aware of?
Yes, definitely. For men, environmental toxins like lead or pesticides are risk factors. Frequent exposure of the genitals to hot temperatures, such as in steam rooms or hot tubs, can negatively impact sperm production.
Right, the heat issue.
Exactly. Similar to women, having a mother who took DES is a historical risk. Certain prescription drugs, particularly anabolic steroids, can impair male fertility. Medical conditions like mumps after puberty, prostatitis, undescended testicles, or a history of hernia repair also contribute. STDs are also a risk. Male fertility can also decline significantly after age 40, and obesity or excess weight is another general risk factor. Understanding these factors empowers individuals to make informed choices that can optimize their fertility journey.
It sounds like a fertility journey often begins with a thorough deep dive into medical history and a comprehensive look at both partners. When someone has been trying for a while, what's the first step they should take professionally? Where do they go?
The first crucial step, if you've been trying for a year or 6 months if you're over 35, is to consult a reproductive endocrinologist.
Okay, a specialist.
Yes, This is a medical doctor who specializes specifically in the diagnosis and management of infertility. They are the experts in unraveling these complex issues.
And what does that initial assessment involve? Is it just a quick chat?
Far from it. It begins with a very thorough medical history for both partners. This includes detailed questions about menstrual cycles, any pre-existing medical conditions, and a comprehensive physical examination for both individuals. This initial assessment helps the specialist determine the most appropriate diagnostic tests moving forward. It's about building a complete picture before jumping to any conclusions or treatments. Hashtag 3.2 laboratory and imaging tests for women.
Okay, once that initial assessment is done, the next step is often a battery of tests to really pinpoint the issue. For women, these include various lab tests and imaging.
Right, these diagnostic tools are like detective work, helping specialists pinpoint exactly where the challenge lies. Is it an ovulatory issue, a structural problem with the tubes or uterus, or something else entirely? Blood tests are critical for evaluating egg supply and ovulation. This includes ovarian reserve tests like follicle-stimulating hormone, or FSH, and anti-Mullerian hormone, AMH.
FSH and AMH.
Exactly. These give a snapshot of a woman's remaining egg supply.
And what about confirming if ovulation is even happening consistently? How do they check that?
For ovulation, they'll check progesterone levels, especially to confirm that ovulation has occurred. Prolactin levels are also checked, particularly if hyperprolactinemia is suspected, along with luteinizing hormone, LH. Thyroid function tests are also standard, as thyroid imbalances can significantly impact fertility. And for a simple at-home method, basal body temperature tracking can help determine if ovulation is happening, though it's typically combined with more precise medical tests.
So beyond blood tests, how do doctors get a visual of what's going on inside the reproductive system?
Imaging tests are essential for visualizing the reproductive organs and their function. Ultrasounds are standard, either with a transducer on the abdomen or, for better images, a transvaginal ultrasound, where the transducer is placed in the vagina. These are often used for an antral follicle count, or AFC, to assess ovarian reserve.
And then there are more specialized imaging techniques like an HSG. What exactly is a hysterosalpingography? That's a mouthful.
It is. The HSG, let's call it, is a particularly important diagnostic tool. Think of it like a plumbing check for your reproductive system.
Okay, like checking the pipes.
Exactly. It's an X-ray procedure that uses a contrast dye to check for blockages in the fallopian tubes and to identify any uterine abnormalities. Its primary purpose is to ensure the egg can travel freely to the uterus and that the uterus itself is suitable for implantation. It can reveal blockages from conditions like fibroid removal, endometriosis, or past STIs like chlamydia or gonorrhea, or even uterine irregularities like scar tissue or polyps.
What does that procedure actually feel like for the patient? It sounds a bit intimidating.
It's a quick outpatient procedure, typically only taking a few minutes. You lie down, a speculum is inserted, and then a thin tube fills the uterine cavity with contrast dye. X-ray images are taken in real time. If the dye flows freely through the fallopian tubes and spills out near the ovaries, the tubes are clear. If it doesn't flow, it suggests a blockage. Preparation is key. You shouldn't be pregnant or bleeding, and you need to inform your doctor about any allergies, especially to iodine or contrast dye. It's best done when you're not on your period. You might experience mild discomfort, dizziness, or lightheadedness, so it's wise to arrange a ride home.
And what about after the procedure? What should someone expect?
Afterward, you can expect some cramping and maybe some bloody vaginal discharge, so it's always recommended to use a pad, not a tampon. Dizziness, upset stomach, or nausea are also possible, but usually mild. The risks are minimal, with very low radiation exposure that won't impact future pregnancies. Rare complications, less than 1%, include uterine injury, infection, or an allergic reaction to the dye. It's crucial to watch for warning signs of infection like fever, chills, vomiting, or severe stomach pain. These require immediate medical attention.
Is there any truth to the idea that an HSG can actually improve fertility, not just diagnose? I've heard that floating around, like it flushes things out.
Well, while some studies suggest that an HSG performed with an oil-soluble dye may slightly increase pregnancy chances by clearing small, minor blockages, the quality of that evidence is low. It's important to understand that HSG is primarily a diagnostic tool, not a treatment.
Okay, diagnosis first.
Right. If significant blockages are found, further surgical intervention or other fertility treatments like IVF are typically recommended. Finally, other imaging tests like a hysteroscopy, which uses a lighted camera through the cervix to view the uterus, and a laparoscopy, a minimally invasive surgery to view the fallopian tubes and ovaries, may also be used depending on the suspected issues. Each test serves a unique purpose in building a complete picture. Hashtag tag tag 3.3 diagnostic tests for men.
It's so crucial that the diagnostic process isn't solely focused on the female partner. It truly is a two-person journey, and the male partner's health is just as integral to the picture. What tests are typically involved for men when fertility is being investigated?
You're absolutely right. The male evaluation is just as vital for a successful outcome. For men, diagnostic tests usually begin with blood tests to check hormone levels, particularly testosterone. This helps assess overall hormonal balance relevant to sperm production.
And then the most common and probably the first test, I imagine, is semen analysis.
Precisely. Semen analysis is the fundamental test here. It assesses several key aspects of sperm health. Sperm count, which is simply the number of sperm present.
Right.
Motility, which refers to their ability to move effectively and quickly.
How well they swim?
Exactly. And morphology, which is their shape. These three factors are primary indicators of male fertility and give a foundational understanding.
Are there any imaging tests for men similar to what women undergo to check for physical issues?
Yes, an ultrasound may be performed to check for any physical obstructions or structural problems within the male reproductive organs, such as blocked ducts or testicular issues like varicosities. An STD test is also common, as infections like chlamydia can negatively affect male fertility.
What happens if these initial tests show an abnormality? Does it mean the end of the road for male factor?
Not at all. If the semen analysis is abnormal, or if the man's medical history suggests a need for deeper investigation, he may be referred to a urologist or a male reproduction specialist. These specialists can conduct a more in-depth evaluation and provide targeted solutions. Additionally, if there's any suspicion of a genetic reason for male infertility that could be passed on to children, genetic counseling and further blood tests might be recommended to understand any hereditary factors. This comprehensive approach ensures all potential factors are considered for both partners, painting a complete picture.
This sounds like the back-to-basics advice that often applies to overall health, but it's particularly vital when trying to conceive. So let's start with lifestyle changes. What are the foundational steps that can be taken that truly make a difference? Can they really move the needle?
They absolutely can. Optimizing overall health is indeed foundational and can significantly impact fertility for both partners. The most crucial steps include maintaining a healthy weight. This is essential because both being very overweight or very underweight can disrupt the delicate hormonal balance needed for conception.
Okay, weight is key.
Yes. Eating a nutritious and balanced diet provides the necessary building blocks and nutrients for optimal reproductive health. And crucially, quitting smoking, recreational drug use, and heavy alcohol consumption are vital. These substances can negatively impact egg quality, sperm production, and overall reproductive function.
Things we know aren't great for general health anyway.
Exactly. These positive steps can set the stage for better outcomes, whether pursuing natural conception or alongside medical treatments by creating the healthiest possible environment for a pregnancy.
So once those foundational lifestyle adjustments are in place, what's the next line of defense in terms of medical interventions? It seems like medication is often a first step for many.
That's right. And what's particularly powerful here is how targeted these medications can be. They're not a one-size-fits-all solution, but rather precisely address specific hormonal imbalances to encourage natural processes like ovulation. For instance, medications can be used to regulate abnormal hormone levels that affect ovulation, such as improving thyroid function if it's overactive or underactive.
And what about stimulating egg production itself for those who aren't ovulating regularly?
That's where ovulation induction drugs come in. Fertility drugs like clomiphene, often known by the brand name Clomid, or gonadotropins, which are injectable hormones, are commonly used to stimulate the ovaries to produce and release eggs. They essentially help the body get back on track or, boost its natural cycle.
Earlier you mentioned hyperprolactinemia, which can really throw ovulation off. Are there specific medications for that, and how do they work?
Yes, for high prolactin levels, medications known as dopamine agonists are highly effective. The two primary ones are bromocriptine and cabergoline. These drugs work by reducing prolactin levels, which in turn can shrink pituitary tumors if they are the cause, and crucially, help regulate ovulation and restore fertility. It's a very direct intervention for that specific hormonal imbalance.
Can you tell us a bit more about each of them and what a patient might experience, side effects, etc.?
Certainly. Bromocriptine has a long track record of safety and is often recommended for women hoping to conceive. It can be taken orally or vaginally once or twice daily until pregnancy is achieved. It may take a few months to reduce prolactin to a normal level, but once achieved, ovulation often resumes. Cabergoline is a newer drug and is generally preferred due to better patient tolerance, less frequent dosing, typically once or twice weekly orally, and often higher efficacy. It's frequently used if bromocriptine isn't effective or causes significant side effects. And side effects. Like many medications, these can have some temporary side effects as your body adjusts, such as low blood pressure, nausea, maybe some mental fogginess or dizziness, but they typically subside over time. For pituitary tumors larger than 10 millimeters, medication is usually used to shrink the tumor before conception. In rare cases, if medication isn't sufficient, surgery to remove the tumor might be recommended before pregnancy. Hashtag tag tag 4.3 surgical interventions.
So, if the diagnostics reveal a physical barrier that medication can't fix, surgery can often literally clear the way for conception. What kind of structural problems can be corrected surgically?
Surgery plays a crucial role when there are specific anatomical issues contributing to infertility. This includes procedures to remove uterine polyps or fibroids, which are non-cancerous growths that can interfere with implantation or cause problems with pregnancy. It also covers addressing scar tissue within the uterus or fallopian tubes, which might have been identified through diagnostic tests like an HSG. The scarring can be a result of infections or previous surgeries.
Are there specific conditions beyond just growths or scar tissue that surgery can treat?
Yes, absolutely. Surgery can be used to treat conditions like polycystic ovarian syndrome or PCOS, where certain ovarian procedures might improve ovulation, or endometriosis by removing endometrial tissue that has grown outside the uterus and is causing blockages or pain. In men, a testicular varicocele, those enlarged veins in the scrotum that can affect sperm quality by raising testicular temperature, can also be corrected surgically.
So, if blockages are found after a test like an HSG, surgery can be the next step in making that pathway clear, getting things flowing again.
Precisely. If fallopian tubes are blocked after an HSG test, surgical interventions such as laparoscopy, which is a minimally invasive procedure, or laparotomy, a more traditional open surgery, may be necessary to clear them and restore the path for the egg. These interventions are often critical for allowing conception to occur naturally or for making assisted reproductive technologies more effective by optimizing the physical environment. Hashtag 4.4 Advanced Assisted Reproductive Technology, ART.
For many, the journey leads to more advanced options, especially if other treatments haven't been successful. Assisted reproductive technology, or ART, plays a really significant role in modern family building, helping countless couples achieve their dreams.
It truly does. To put it in context, approximately 2.3% of all infants born in the United States are conceived with RT.
Wow, 2.3%. That's more than I would have guessed.
It highlights how integral these technologies have become to helping individuals and couples achieve their family dreams, offering hope where traditional methods might not suffice.
Let's start with intrauterine insemination, or IUI. What does that involve, and how does it differ from just trying naturally?
With IUI, a fertility specialist carefully transfers specially prepared sperm, either from a partner or a donor, directly into the uterus using a thin catheter. This procedure is often coordinated with ovulation, sometimes after fertility drugs have been administered to the woman.
So it gives the sperm a head start, basically.
Exactly. The key mechanism here is that IUI bypasses the need for sperm to travel through the vagina and cervix, placing it much closer to the egg in the fallopian tube, thereby significantly increasing the chances of fertilization. It's a less invasive step, often tried before moving to IVF.
And then there's in vitro fertilization, IVF, which is probably the most widely recognized and often the most intensive RT procedure.
IVF is a more comprehensive, multi-step process. Eggs are retrieved from the woman's ovaries, or donor eggs are used, and then combined with sperm again, from a partner or donor in a laboratory setting. Once fertilization occurs and embryos develop, one or more selected embryos are then carefully transferred into the woman's uterus. Fertility drugs, typically gonadotropins, are administered beforehand to stimulate the ovaries for egg retrieval.
And sometimes they add another step, ICSI.
Right. A common addition to IVF, particularly in cases of male infertility or when there are issues with fertilization, is intracytoplasmic sperm injection, or ICSI. That's where a single sperm is directly injected into a single egg to ensure fertilization, and the resulting embryo is then transferred to the uterus.
We have a personal anecdote from Kathy Peshek that really illustrates the reality of the IVF journey. It's not just a sterile medical process, it's a profound, all-encompassing experience, isn't it?
It truly is. This raises an important question about the commitment and resilience required for IVF. While it offers incredible possibilities, it's a profound journey, both physically and emotionally, as Kathy's story so vividly illustrates. Kathy was diagnosed with PCOS at 33 after a year of irregular periods and not conceiving. Her ovaries had many follicles, but she wasn't ovulating. IVF was chosen because it circumvented the need for natural ovulation, offering a direct path to conception.
And her experience sounds incredibly intense and demanding, just reading about it.
She described an incredibly intense process. Kathy administered 3 shots to her stomach daily, took large pills, and experienced significant physical discomfort. She felt swollen, was crying and throwing up, and was constantly tired. The frequent clinic visits, every other day for 30-minute transvaginal ultrasounds, added to the burden, especially with a 30-minute drive each way to the fertility clinic. It becomes a central part of your daily life.
That's a huge time and energy commitment, not to mention the financial aspect. I know that's a major concern for many.
Absolutely. Kathy and her husband had to take out a substantial $30,000 loan to pay for their treatment, highlighting the significant financial burden many families face.
$30,000.
Yes. And the emotional toll was equally immense. Kathy expressed feeling guilty that her body was the problem and found it hard to accept she might never conceive naturally. She described feeling like her life was restricted, constantly treating her body like it was pregnant, even before conception, avoiding wine, strictly controlling her diet, and focusing on rest. She noted that everything was changing, and while she desperately wanted to be a mom, it was still a shock to her system, requiring a massive mental and physical adjustment.
And despite all those challenges, what was the outcome of her first IVF cycle? Did all that effort pay off?
It did. Her first egg retrieval in June 2019, after 4 months of preparations and a month of shots, yielded 39 eggs, with over 20 mature ones. They ended up with 3 healthy embryos.
3 embryos from 39 eggs.
Yes. 2 months later, a successful embryo transfer led to the birth of her first son, Miles, in April 2020. 2 years later, a second embryo transfer resulted in her second son, Henry, born in September 2022. Kathy noted that the second IVF cycle was even harder, while she was also caring for a toddler, adding another layer of complexity to the demands. Her story really underscores the immense physical, emotional, and financial commitment involved, but also the incredible possibility of creating a family through IVF despite significant hurdles.
It's so easy to fall for clever marketing or hopeful anecdotes when you're trying to conceive, especially online. But here's where it gets really interesting. Science says these viral trends often don't hold up. Let's talk about a big one. It's like thinking seeing a mechanic means you're definitely getting a new engine. Often it's just a checkup or a minor repair. There's a really common misconception about seeing a fertility specialist. What is it, and what's the reality for someone just starting out?
What's truly insightful here is how perceptions can be shaped by limited information. And this misconception can be a significant barrier to seeking help. The key misconception many people have is that seeing a fertility specialist automatically means you're going to undergo IVF.
Right, that it's the only option they offer.
Exactly. That simply isn't the case, and it can deter people from getting the initial evaluation they need.
And the reality is much broader than that. They have a whole spectrum of approaches, right? Not just jumping to IVF.
Absolutely. Fertility specialists, such as reproductive endocrinologists, can actually provide a wide range of tests and screenings that don't always lead to advanced fertility treatments like IVF. Their role is to help identify the underlying issues, many of which can be addressed with much less invasive solutions first. They are problem solvers. They're equipped to handle a spectrum of challenges, from simple hormonal imbalances to complex structural issues, with IVF being just one tool in their extensive toolbox. They can help you understand your body, whether that leads to lifestyle changes, medication, or more advanced procedures, tailoring the approach to your specific needs. #HackFA 5.2 platelet-rich plasma, PRP, for fertility.
Shifting gears to emerging treatments, there's a lot of buzz around platelet-rich plasma, or PRP, for fertility. It sounds cutting edge, but what exactly is PRP and where does it come from?
PRP involves injecting concentrated platelets derived directly from a patient's own blood into specific areas to accelerate natural healing. It's not entirely new to medicine. It's actually been used for nearly 40 years in various fields, from treating sports injuries and arthritis to hair loss, and even for skin rejuvenation. The idea is to harness the body's own healing powers.
So how is this technique being applied to infertility specifically, and is it proving effective yet? Is it still mostly theory?
For infertility specifically, PRP is still very much in experimental stages, with clinical trials currently ongoing across the country. The theory is compelling. Platelets are packed with growth factors, proteins, and other substances that promote cell growth and stimulate healing. The hope is that injecting PRP into the ovaries or the uterine lining could improve the local environment.
Improve how?
Well, for example, it's being researched with the hope of thickening the uterine lining for more successful IVF implantation, and potentially increasing the number of mature eggs and anti-Müllerian hormone, or AMH, levels in women with poor ovarian response, like Alex Nichols. However, it's crucial to remember there's still a lack of definitive, large-scale clinical data.
What does the procedure for PRP actually look like for fertility patients? How is it administered? Is it painful?
It's an outpatient procedure. First, blood is drawn from the patient, then separated into components and processed to concentrate and activate the platelets. The activated PRP solution is then prepared. The application depends on the goal. If the uterine lining needs thickening, the plasma is injected into the uterus via a catheter, which usually doesn't cause pain. If the aim is to improve egg quality, the PRP is injected directly into the ovaries with an ultrasound-guided needle, which does require anesthesia to prevent pain and ensure the patient remains perfectly still.
And what's the timeline for seeing effects, and how often can someone undergo this treatment? Is it a one-time thing?
After either procedure, patients typically need to wait at least 1 month before starting an IVF cycle for the platelets to release their growth factors and for any potential effects to manifest. Those effects are thought to last for about 3 months, and the procedure can be repeated after 6 months if needed. But again, this is all part of ongoing research into its long-term efficacy.
So on the research side, what's the evidence looking like? We hear powerful anecdotal stories, but what about the hard science that doctors rely on?
This raises an important question about the balance between hope and evidence in medicine. While individual stories like Alex's are incredibly powerful and offer a glimpse of hope for broad clinical recommendations, the scientific community really emphasizes the need for rigorous, large-scale studies. Anecdotally, some practitioners report positive early results, and small studies have shown promise. For example, one study of 38 women with low ovarian reserve resulted in 10 pregnancies and 6 healthy babies.
Okay.
Another study of 83 women with a thin endometrium showed a 32% pregnancy rate with PRP versus 14% without.
Those numbers sound encouraging, especially for those who feel like they've tried everything.
They do, and it's why there's so much interest. However, medical experts caution that many of these studies are small and not rigorously designed enough to draw definitive conclusions. None have definitively proven that PRP alone caused the pregnancies, as other factors could be at play. Dr. Sasha Hackman, a double board-certified OBGYN and reproductive endocrinologist, notes, "It's always possible that it worked by chance and that it wasn't really the PRP that led to success." That's why in the medical field, we really stress the importance of high-quality randomized clinical trials, so we know this was not due to chance alone, but to the therapy.
Right. Correlation isn't causation.
Exactly. It's also difficult to compare PRP to other treatments, as there are no other options similarly injected directly into the ovaries, except for stem cell treatments, which are even earlier in their research. More robust clinical trials are needed to determine who benefits most and what the optimal protocols are.
Given that it's still considered experimental, what's the cost, and is it covered by insurance? I imagine it's pricey.
As PRP for fertility is still considered experimental, it's generally not covered by health insurance, even fertility-specific insurance plans. Patients can expect to pay a significant out-of-pocket cost, typically between $2,000 and $4,000 for the procedure, depending on the clinic and location.
$2,000 to $4,000. Okay. And what about safety? Since it uses the patient's own blood, I imagine it's relatively safe compared to other more invasive procedures.
Generally, yes, it's considered safe because it uses the patient's own blood, leading to a very low chance of rejection or adverse reactions. In fact, studies haven't reported any serious side effects. However, there are a few theoretical risks, though they are rare, less than a 1% chance.
Like what?
For intrauterine PRP, there's a minimal risk of infection or a perforation in the uterus from the catheter. With ovarian PRP, there's a very small risk of infection, bleeding, or damage to nearby organs from the needle.
So for someone considering it, what's the final advice from experts? Is it something they should jump into or wait and see?
It's still too early for definitive results regarding PRP injections for fertility. While individual successes like Alex Nichols, who was 36 and had poor ovarian response but conceived her son after trying PRP as a last resort, are compelling, experts like Dr. Hackman advise that it's not like this big medical breakthrough yet. The strong recommendation is to discuss it thoroughly with your doctor, understand the current evidence or lack thereof, and inquire about any local clinical trials you might be eligible for if it's something you truly want to explore.
Okay, let's shift from the experimental to the viral. It's so easy to fall for clever marketing or hopeful anecdotes when you're trying to conceive, especially online. But here's where it gets really interesting. Science says these viral trends often don't hold up. Let's talk about the soft cup method. It's been gaining popularity among couples trying to conceive, utilizing menstrual cups marketed for conception support. What's the theory behind it that makes it so appealing? Why are people trying this?
This raises an important question. Why do these methods gain traction despite limited evidence? It often comes down to the emotional vulnerability inherent in trying to conceive. Critical thinking is essential in a world of information overload, especially when there's so much hope involved and people are desperate for a solution. The theory behind the soft cup method is that by inserting a menstrual cup immediately after sex, it keeps sperm closer to the cervix and inside the vaginal canal for a longer period, thereby theoretically increasing the chances of sperm reaching the egg.
It sounds logical on the surface, keep everything contained.
Right.
We've seen a lot of anecdotal claims of success online, like Emily Rapp and Alexia Brewster sharing their stories on social media. But what does the medical evidence say? Does that theory actually translate into results?
Crucially, medical experts, including Dr. Brooke Rossi and Dr. Sasha Hochman, make it very clear that there is no scientific evidence that the soft cup method provides any advantage over simply having unprotected sex.
Oh, none at all.
No proven advantage. They liken the theory to other unproven beliefs, such as specific sexual positions or elevating legs post-intercourse to aid conception. These haven't been scientifically proven to work either. BabyCenter community mom Regina Jones, for example, tried soft cups and other methods without success, eventually conceiving only after stopping attempts, highlighting the power of chance.
Is it at least safe to try if it offers hope, even if it's not proven? Or are there risks?
Generally, it's considered safe if directions are strictly followed. This means ensuring the cup and your fingers are disinfected to prevent bacterial introduction. It's also vital not to leave it in longer than directed, typically 20 to 60 minutes. Leaving it in for over 12 hours significantly increases the risk of infection, though the risk of uterine perforation is minuscule. The cup is inserted like a tampon, with the rim positioned a few inches below the cervix.
What about combining it with at-home insemination kits? Is that a next-level approach people are trying?
Experts advise against combining soft cups with at-home insemination kits, like Mosey Baby, again due to a lack of evidence supporting their efficacy together. The most effective scientifically backed ways to maximize your chances of pregnancy remain focusing on tracking ovulation accurately, maintaining a healthy diet, and a healthy lifestyle. If you have concerns, consulting an OB/GYN or a reproductive endocrinologist for evidence-based advice, testing, and treatment is always the best and most effective approach. Prioritizing proven strategies can save both time and emotional energy.
It's a journey that doesn't just impact the body, it weighs heavily on the mind and heart. The emotional and psychological toll is often as challenging, if not more so, than the physical aspects of treatment. What kind of psychological toll does infertility take on individuals and couples? It sounds immense.
It is. Infertility can evoke a wide range of intense feelings, creating a true emotional landscape. We see anger, deep sadness, periods of depression, anxiety, and profound frustration. Perhaps the most hidden struggle isn't the physical treatments, but the profound sense of isolation and guilt many feel, believing their body has failed them, even when medically it's just a complex biological hiccup. This loss of self-esteem is candidly shared by Kathy Pashek in her story, who felt her body was the problem, leading to a pervasive sense of guilt and self-blame, even though it's not their fault.
And it's not just the emotional drain, but the practical burdens too, like the financial side we touched on.
Exactly. The process is emotionally draining and can be financially heavy, particularly with treatments like IVF. Kathy's story, for example, highlighted the substantial $30,000 loan she took for her treatment, a reality for many. Beyond that, coping with the psychological and physical side effects of fertility medications and hormones adds another layer of stress. For those with secondary infertility, the unexpected challenges and the difficulty of conceiving after previous ease can be particularly shocking and hard to accept, compounding feelings of loss and disbelief and creating a unique emotional burden. #hashtag 6.2 Essential Coping Mechanisms and Support Systems.
So, with such a heavy emotional toll, what are some of the most effective coping strategies for navigating this journey? It seems like finding support is crucial. You can't go through this alone.
You're right. If we connect this to the bigger picture, these coping strategies are not just about managing symptoms of distress. They are integral to building resilience and maintaining well-being throughout what can be a very demanding journey. Critical thinking also applies to self-care, understanding what genuinely helps you cope. First and foremost, Seeking and building community support is vital. Connecting with others who have experienced infertility can alleviate feelings of isolation and provide invaluable emotional validation, making you feel less alone.
Like the support groups we hear about in the sources, online or in person.
Precisely. This can be done through online support groups, such as the Secondary Infertility Group in the BabyCenter community, or through established organizations like Resolve, the National Infertility Association, which sponsors various support groups. As one BabyCenter community mom wisely shared, talking and sharing our stories is what helps us move forward, let go of shame and resentment, and helps us to heal. It's a powerful act of collective healing.
Beyond community, what about personal empowerment? Through knowledge and being proactive with your medical team, does that help manage the anxiety?
Yes, definitely. Learning as much as possible about your specific diagnosis or situation, coupled with actively collaborating with your doctor to develop a clear plan of action, can help restore a sense of control and reduce anxiety in an otherwise overwhelming situation. This educational aspect is truly empowering and allows you to feel like an active participant in your journey.
And what about basic self-care, which can sometimes feel impossible when you're going through something so intense? It's easy to let that slide, isn't it?
It is, but self-care is paramount, and it's often overlooked. Maintaining overall health by committing to a healthy diet, ensuring adequate sleep, and engaging in regular exercise is crucial, as these support both physical and mental well-being. Beyond that, stress reduction techniques like meditation, deep breathing exercises, and progressive relaxation, mindfully relaxing one body part at a time, can significantly help manage stress levels. It's also perfectly acceptable and often necessary to take breaks from daily routines or even parenting responsibilities if applicable. Leaning on friends, family members, or hiring babysitters can provide much-needed time for personal rejuvenation.
I can imagine the pressure on a couple's intimacy can also be immense when sex becomes so scheduled and goal-oriented. How do couples navigate that?
That's a really common challenge. Infertility can turn sex into a chore due to its goal-oriented nature. Open communication with your partner is vital. Explore other forms of physical intimacy, such as snuggling or giving massages. Remember to also engage in sex simply for pleasure, outside of scheduled fertile windows, to maintain that connection and protect the emotional bond. Finally, if the emotional toll becomes overwhelming, or if you're experiencing anxiety or depression, do not hesitate to seek professional counseling.
Talking to a therapist.
Yes. Ideally, find a therapist who's familiar with fertility problems, as they can provide specialized support and coping techniques. Your doctor or midwife can offer referrals. Seeking help is a sign of strength, not weakness, and is an integral part of navigating this challenging journey.
Kathy Peshek's story is such a powerful reminder that life can throw the most incredible curveballs, even when you think you know your body and your path. We left Kathy's story after she had 2 sons through successful IVF due to her PCOS, but her fertility journey didn't end there, did it? What happened next? It's quite something.
It really is. After the intense experience of 2 successful IVF pregnancies, Kathy and her husband had actually planned to wait until their second son was 3 years old before even considering using their last embryo for a third child. They felt their family was complete for the moment, having navigated so much to get their 2 boys.
But then life had other, utterly surprising plans, didn't it? Completely out of the blue.
It did, and in a way that truly defied expectations. When her second son was just under 2, Kathy began experiencing symptoms like emotional agitation, nausea, and feeling generally unwell. She initially suspected an ovarian cyst rupture, a known downstream effect of PCOS that she was familiar with.
Okay, something related to her known condition.
Right. During a routine doctor's visit, a urine sample was taken. To everyone's astonishment, her doctor called her while she was driving home to inform her that her pregnancy test was positive she was 9 weeks pregnant, naturally.
Naturally. After needing IVF twice, that must have been an absolute shock. I can only imagine her reaction.
Kathy described being at a loss for words, stunned, and just started laughing, struggling to comprehend how she became pregnant without medical intervention after all her IVF history. She kept thinking, wait, how did I get pregnant? Her joy was profoundly mixed with anxiety about managing 3 children and immediate concerns about the pregnancy's health, given the absence of the rigorous monitoring and preparation associated with IVF. Her OBGYN, clearly accustomed to such rare but amazing occurrences, acknowledged, "It happens, never say never," confirming that natural conception after IVF, while uncommon, does occur. Kathy couldn't believe it happened to her, of all people, after such a long struggle.
And what was the outcome of this unexpected third pregnancy? Was it smooth sailing, or did more challenges arise? It seems her journey always had twists.
Her third son, Owen, was born on September 10th, 2024, early via an emergency C-section at 31 weeks. This was due to a uterine window, a thinning of the uterine wall from her previous two C-sections.
Oh, wow. Another complication.
Yes. Owen, being premature, required a 58-day stay in the NICU due to respiratory failure, which was, as Kathy described, a deeply draining and emotionally exhausting experience for the family, adding yet another unexpected twist to their journey. During that C-section, Kathy opted for a self-injectomy, which is the removal of her fallopian tubes for permanent contraception, having decided that three rambunctious boys truly completed their family.
What was her reflection on this incredible, unpredictable journey, having experienced both intense medical intervention and a complete surprise? How did she process it all?
Kathy expressed wishing she had known more about PCOS earlier in life, understanding its complexities. She conveyed immense gratitude for her support system, doctors, friends, and family, who helped them navigate both the expected challenges of infertility and the many unforeseen twists of her third pregnancy. Despite the chaotic and unexpected nature of Owen's arrival and NICU stay, she ultimately felt it was what was supposed to be, and that her family was truly complete. Her journey truly exemplifies the unpredictable nature of fertility, reminding us that life can defy all expectations, even after years of struggle. #outro.
So what does this all mean when we bring it all together? We've unpacked the precise medical definitions of infertility, highlighting that it's a remarkably common experience affecting both men and women, with clear guidelines for when to seek professional medical help based on age and duration of trying.
And we've thoroughly explored the diverse and intricate causes of infertility, ranging from hormonal imbalances like PCOS and hyperprolactinemia to structural issues in the reproductive organs and even genetic predispositions, emphasizing the critical need for comprehensive evaluation of both partners to pinpoint the specific challenges.
We detailed the crucial diagnostic tools, from blood tests and ultrasounds to specialized procedures like HSG, which help pinpoint specific challenges and guide treatment. We also discussed the full range of evidence-based treatment options available today, from foundational lifestyle changes and targeted fertility medications to advanced assisted reproductive technologies like IUI and IVF, acknowledging the significant commitment and emotional journey involved in each.
And we've examined promising but still experimental frontiers like PRP therapy, emphasizing the need for robust scientific evidence, and debunked unproven methods like the soft cup method, reinforcing the importance of evidence-based approaches over anecdotal trends and hopeful marketing.
And finally, we've deeply explored the profound emotional and psychological impact of infertility, underscoring the critical need for self-care, strong support systems, and professional counseling throughout this challenging yet hopeful journey, powerfully exemplified by Kathy Peshek's truly surprising and unpredictable personal story. So what does this all mean when we bring it all together? Perhaps the biggest takeaway from this deep dive is that while medical science offers increasingly sophisticated tools and understanding on the journey to conception, there remains an undeniable element of profound mystery, individual variation, and sheer resilience in the process of creating life. It invites us to consider, how can we, as a society, not only continue to advance the science, but also better support and destigmatize the incredibly personal and often hidden experiences of those navigating fertility challenges, recognizing both the medical realities and the powerful human spirit at play.
This raises an important question. Beyond the clinical definitions and treatments, what role does community, open dialogue, and a compassionate understanding of the human experience play in transforming what can be a lonely and overwhelming journey into one of hope and shared strength? What stands out to you about the balance between medical intervention and the inherent unpredictability of life when it comes to creating a family?